So before we introduce our first speaker, which is Dr. Michell Chresfield, you'd have seen on the screen, I do have a poll. So this is the poll number 1. And the question is, how would you describe your change in thinking about taking the COVID-19 vaccine from the start of the rollout compared to now? So you'll see the question again, so I'll just say that now. So I'm going to launch it. Is it launched already? Yeah, it's launched already, I think. And it's waiting for you now to respond. Wow, okay. Let's give it a few more moments. Okay, there's 10 out of 19 that's responded. So if people are not sure, we'll just give you another maybe 20, 30, 20 seconds or so. Okay, so it looks like 50% has participated. So if I end it, will you all see it? Okay, it's 12. Okay, right, I'm glad I waited. So let me just, okay, 12 out of 12 have answered, it said. Okay, right. Okay, fine, that's fine. Okay, let me just get rid of this. Right, I'll share the results now. So from the start, definitely no to the jab. Now I'll wait. And 17% have said yes to the jab, 33% I'll wait, 8% definitely no to the jab, and 25% yes to the jab. Okay, I think we've got some insight there. Brilliant. Okay, our first speaker for this evening, right, is Dr. Marion Johnson. Now, each speaker has 10 minutes. After 8 minutes, I'll send you a note in your chat box, so keep an eye on your chat box. About 8 minutes, I'll be asking you to wind down or to kind of end what you're going to say. You've been briefed already, so being the professional that we are, we'll keep to the time of 10 minutes, and it's 10 minutes GMT. I'm sure we're all aware of that, and for those, it means Greenwich Mean Time, so it's 10 minutes, but hopefully we don't go over the 10 minutes that's been allocated for you. So Dr. Michell Chresfield, would you like to come forward to the mic, so to speak, and state your case? Thank you. Yes. And I'll be timing all the talks.
Awesome. Thank you for that. Everyone, thank you for allowing me to be here with you this evening. I join you from Birmingham. So I'm an American academic. I'm a researcher on the history of race in medicine. And I mostly focus on the US context, but since coming to the UK, have really begun to think about the kind of transatlantic and diasporic dimensions of race in medicine. And so in my talk today, I want to talk to you about some of the data that you may be grappling with as you think through your stance on the vaccine. So as a historian of race in medicine, a lot of the data that I deal with, so to speak, is the history of racism and how this impacts contemporary access to healthcare. And I know from speaking to people in kind of many walks of life that the reasons for vaccine hesitancy are myriad. But I think it's worthwhile to think through how particular histories of medical racism might be influencing contemporary hesitancy, either directly or indirectly. So if you were to read articles and hot takes from both sides of the Atlantic, a recurring reason for explaining vaccine hesitancy is the infamous Tuskegee experiment. And so maybe some of you will know it, maybe some of you will not. It might not even be a reason that you cite. But the Tuskegee experiment happened in Tuskegee, Alabama. It began in 1932 and was a study sponsored by the United States Public Health Service, so our official research arm in the United States. The study, commonly known as Tuskegee, developed into a 40-year longitudinal study interested in understanding the disease course of untreated syphilis in African American men. And it focused on a population of 399 men who were known to be infected. And then they added later another 201 men who were free of the disease. So the ethical and medical horrors of Tuskegee are probably well known to many. There was the absence of informed consent, meaning that many of these men did not know kind of what the study was, nor did they know kind of the disease that they were diagnosed with. There is a Southern euphemism called bad blood, and so many of these men just knew that they had bad blood. But perhaps the most egregious aspect was that these men were deliberately kept from accessing penicillin once it became known as an effective treatment for syphilis. Instead, these men were given placebos, such as aspirin, and subjected to painful spinal taps in order to procure data for the study. As a result, over the years, men died, they went insane as they contracted neurosyphilis, and they unwittingly passed on the disease to their partners and to their children. So by 1972, when a whistleblower blew the top on Tuskegee, the study is still going. By that time, 30 men had died of syphilis itself, another 100 from related diseases of syphilis. 40 spouses had been diagnosed and died with the disease, and another 19 children had died in childbirth. So the legacy of Tuskegee is heinous in that it functions in the Black imagination as a kind of shorthand for medical racism. But perhaps another historical example that might come to mind is not Tuskegee. Perhaps it is the smallpox inoculations that were performed on enslaved populations in Jamaica in the 18th century. Their inoculations are a precursor to vaccines, and they featured on as many as 850 enslaved people. And another example involves also the 19th century when Britain's Anthropological Society endorsed a request to procure blood samples from inhabitants of African countries and send those samples back to London. One of the aspects of that is that they thought that this blood would be useful as a kind of data procurement as they investigated diseases and to kind of highlight the kind of particular biologies of these populations. And some of you may know that a lot of this blood is still being frozen in places like Cambridge and Oxford. And thanks to the storage, and as well as in places, North American laboratories. And thanks to the storage practices, this blood is kept for so long. So, you know, the first requests go out in the kind of late 19th century. By 1959, some of these samples from the Belgian Congo, for instance, played an important role in the genetic time sequencing of different strains of HIV. So in all of these cases, Black bodies have been used as data or to procure data on diseases. Of interest to me as a historian is the historical tension between framing Black bodies as inherently different, as well as the one that frames Black bodies as important vessels through which to glean information. And simultaneously, in our history, Black people have been both. Yet, as horrifying and shameful as these examples are these the real reasons that people are hesitant? And I think, you know, that's what makes events such as this so important. It's important for us to talk about and hear and engage with the reasons why. Um, what I have found and what some of the early kind of medical research is indicating is that, in fact, Black people are much more likely to point to contemporary aspects of medical racism when explaining their hesitancy. And there's so many great other panelists who would speak to those kind of current examples. But for my case, I want to draw a link between this kind of current hesitancy citing contemporary issues and these events like Tuskegee and in inoculation in Jamaica. One of the things that makes it so hard for our kind of contemporary social critics and commentators to contend with the fact that it's contemporary issues that might be driving how Black people engage with COVID is that it's born of an unwillingness to confront either both our contemporary experiences and existence of medical racism as well as those historical manifestations. one of the reasons that we know about Tuskegee and of the inoculations in Jamaica are because there's such heinous examples. There's so many everyday aspects of when people have their illnesses dismissed or they feel that people talk down to them, that would really create distrust in the community. And so you don't always need to marshal the past as the data to explain your actions in the present. And so this brings me back to data. One of the legacies of Tuskegee is the presumption, and it functions not just in the United States, but in many different contexts where you have Black people, this idea that Black people don't want to participate in medical research as a result to these historical examples. And so as a result, researchers have tended to be a little lazy in attempting to ensure that Black people are subjects. There are certainly exceptions to this, but by and large, Black people remain underrepresented in these studies. And so, how do you ensure that you have representation so that you can cultivate trust when medical researchers are not doing as much as they can to ensure that representation? And there's all kinds of things linked to medical racism that also affects that. And it's not just laziness, the absence of Black people in these studies, the lack of partnerships with hospitals where you have large Black patient populations, comorbidities, as well as that general oversight. And so I think this comes back to this idea that for us to take hesitancy seriously. And so, and again, to reiterate the importance of this evening's panel, because hesitancy isn't necessarily out and out refusal, and thinking about the ways in which hesitancy is used to kind of dismiss the kind of valid critiques that Black people have of the healthcare system. And so it's important for us, if we're ever to kind of ensure our health and make sure that we have the best health outcomes, that we acknowledge our past, right, and its connections with our present. So thank you.
Thank you very much indeed. You kept the time as well.